Good afternoon to you all. I was tasked, as I said in my initial comments, to share with you an experience that is not like the other presentations we've heard, because this is from the side of the government. I'm going to explain how a country makes decisions when there's political will to implement early childhood development policies. And this is a process that has been underway for 3 years. And the idea behind it was to base ourselves on the International Convention on the Rights of the Child and early childhood development. I have 3 different parts to the presentation. At the beginning, I will just quickly say what the country's approach is, and then secondly, the elements of 2 studies that the country has conducted that have to do with investment, and then thirdly, I'll provide some conclusions and general ideas for the dialogue on the implementation of public policy. In the first part, the country initially, this is what we've been working on. This is something we've seen in many Latin American countries. It has to do with traditional ways of working as we manage public policy. And what we found, there are different sectors with different priorities and different development plans and specific investments that look to important goals for the population, but they don't talk amongst themselves, they don't coordinate in practical terms. In the specific case of Colombia, we had all of the local authorities, the education sector, the healthcare sector, society in general, the private sector as well, which is, of course, extremely important in the country. And they each had objectives that were targeting certain part of the population. And the strategy basically looked to reorganize the entire system, the entire institutional framework. And it shifts this paradigm where we have a single entity in charge of early childhood. And it decided to create an institutional framework from the bottom up. It creates an institutional architecture. We have this intersectoral early childhood commission that includes all the sectors from national planning, finance ministry, the different ministries, different entities, and it created a single work plan. And as an ethical framework, the need for protection for children. This is important because Colombia, unlike other countries, is not working from a risk perspective. This is a public policy for the 5 million children who live in the country under different conditions. Colombia is one of the countries with the greatest degree of social inequity in Latin America and globally. It also defines one of its approaches is to make the central objective is not integrated care. That's the how, not the why. So it means not losing sight of the child at any time, not in budgets, indicators, or programs, because they often get lost when we're managing programs. So this was important. So it basically says that we have to have comprehensive development. And very quickly, based on this exercise, it shows a management tool that Colombia is using now, which is an integrated care pathway. And this is where we bring together much of what's been discussed during this workshop. First, to understand differences in development, if we look at the life course and looking at different ages from the preconception conception through 6 years of age, and look at the particular circumstances and how those impact interventions, public policy interventions. And it's not a program, it's a policy framework that brings together about 18 programs, all of which are moving towards intersector approaches, and it is a public policies for developing actions in the home, in healthcare centers, in the communities, and in public. It can't be moving in a single direction or in a single environment. It's got to be something comprehensive. And then finally, we have the structural basis for the different actions and activities. So we engaged in an exercise as to what every child and mother needs for healthy development throughout the entire life course. So we began, this is a complex exercise, and the pathway is 170 different types of activities. There are 8 indicators that the country development with which we began to implement the policy. First, this was integrated development, went from services to more comprehensive actions. This is the focus that the policy has now. As you can see there, we have many different sectors involved, and this is around a single child. This is something that's very complex in public policies because it is a matter of intersectoral management. We have 5 lines of action. I'm going to focus on the second. The first is subnational management, development of knowledge, coverage and quality, monitoring and evaluation of the policy and social movement. Several studies have been conducted. I'll just focus on a few of the specific aspects. The first has to do with developing a baseline to determine quality services and matters of quality in healthcare services and in child development centers. And I have 2 or 3 key slides I want to show you. The first is to understand that in a public policy framework, when we talk about quality and outreach to the population, that is key. What we did was, for some different types of attention, we have quality criteria to create a national database. This is where we believed we had to take action. If we don't invest in quality, this can be counterproductive for the very community we're trying to help. So it's very important to ensure the quality of the investments and to qualify the services and the different activities. Here, I'm not going to spend too much time here, but I wanted to talk to you because it's relevant to what we've been discussing. With great rigor, there have been findings and evidence about the prenatal period and attention for pregnant mothers and early infancy. There are public policies. We were saying, where should we begin? What you're seeing here is the results of a study that show the determination of quality in healthcare services have to do with notification. All of what you see in red show what is not recorded in the medical histories of the pregnant mothers or the child. That means when we start to do follow-up on children, the physician, the obstetrician has no medical records in order to be able to do any monitoring. And we've seen the importance of knowing what the medical history is, or what the health and nutrition conditions of the pregnant mother are. And public policies, these are variables that can make any progress impossible in this direction. The other study has to do with the matter of cost. And here what we basically identified was the following. We defined certain types of interventions, and what you can find here, and I know that it's very hard to read this table up here, but on the left we have the different ages. So what we did was we started to determine costs for services, starting from preconception, from pregnancy till birth, from birth to the first month, or 2 to 5 months, 6 to 11 months, 1 year, 2 years, etc. And at each age, we started to identify what the fundamental services and care were. It was parenting, feeding, nutrition, vaccines, access to culture, physical and recreational activities, learning, schooling, development, screenings, and these transitional periods, prevention, recovery, especially when rights have been violated, and specific healthcare-related issues. So looking at the simple, straightforward costs, and then we started to make comparisons between the different types of services and care. In Colombia, we have what we call kindergartens or daycare centers, where, and I wanted to show you where this arrow is. This is when we're taking care of 1 year old. That can cost 5 million pesos. In dollars, that would be about $2,600 per year. But in another type, under those same conditions, it could be costing the country 1,700, 1,800, and in other community-based services, it could be $800. So when we conducted the exercise, the planners and policymakers were looking at what was the cheapest. But what's the cheapest is not necessarily the best for the country, because it depends on the conditions. In a large city like Bogota, a big metropolis that has a significant population, to have community-based centers doesn't have an impact compared to what is available in rural areas or with indigenous communities, because we have that in the country, or with those who are victims of the armed conflict. So this is something that we also wanted to show here, that when you are doing evaluations or researching programs or different types of care, looking at rules that can be applied from one context to another, you have to take great care in doing that and bear in mind the context, because within a single country the conditions can significantly vary. So if we say this is a good program or a bad program, well, you can say that scientific rigor, and you may not like to hear this, but it depends. It depends for what community and what context and what conditions, and this would warrant perhaps other approaches in evaluating programs and not just talk in general terms, which is what often happens. And some of the conclusions of the studies, it's important in terms of the exercise that we who work in planning and do policy development take into account. It's important to have ex ante and ex post studies that help us to look at the context, and those evaluations or studies that try to just look at a single program don't help us who work in public policy development or planning very much. And this gap that exists in scientific findings and the development of policy is very serious for many countries. In the case of Colombia, when we were looking at the study that showed quality data in terms of healthcare services, a country that doesn't have data, that doesn't have the medical history of a child, or doesn't have any of that information, it's very difficult, very complicated to develop actions that are going to have an impact on childhood development, programs to support families, provide nutrition, nutritional support or look at the nutritional situation of the pregnant mother. If there's no ability to access data, it's very difficult to make significant decisions in terms of education. In the case of Colombia, what we've discovered is that there are many countries, and we know that it's not just in the case of Colombia, early childhood now, there is educational availability. So we're seeing a significant number of persons who can provide those services. That's not just because a law was passed or because quality standards were developed. You have to generate skills, strengthen institutions, and make sure that they're quality services so that in the medium term we can have positive outcomes. It's not just shifting to different approaches. These approaches have to be worked on. You have to make an investment, and one of the major costs that is ultimately has to be paid is to be paying for very costly services that are not having an impact on the children. And if we don't have quality actions, the services will not have the impact we want, and we'll be losing the investment. It will be an investment with a much lower impact than what we would like.
Another element that we'd hope to see include in evaluation agendas has to do with having multiple factors, obviously cost effectiveness, but also an integrated approach to services. In Colombia, it doesn't matter what the environment is. In the health environment, you can provide integrated services, provided that they understand that a child is a whole being with many variables. It's not helpful to us in policy implementation to have the very specific programs or visions because the child is lost. If you talk about nutrition, that can have to do with emotional care, access to other services, bonding or connection with other services. If you don't see it as part of a whole, the exercise can be pointless. So the big challenge in Colombia is to look at all the things that are provided, nutritional recovery programs, reading rooms for families, early childhood education, early childhood health programs. Now it's all moving towards a more integrated system. Now a doctor isn't going to become a teacher, but the doctor needs to understand that he's talking to a child that has feelings, who reads, who has a teacher, who has different sides to him. And it doesn't cost more to have that vision, but the cost of not having that vision can be very high. You can have the nicest doctor's offices, highly trained people, but if the basics are lost at the early childhood level, then the costs are going to be higher to pay down the road, and our actions will have a lesser impact. Two comments that I absolutely need to share with you before I wrap up. First of all has to do with costing. We cost the direct care for the child, the services they receive, but we also have to cost the policy implementation side, and this involves social mobilization, communications, training, supports institutional architectures, and those can be invisible costs oftentimes, and it can be a risk if attention is not paid to those aspects. And then lastly, with a differentiated approach is essential to understanding different needs of different populations. For instance, in Colombia, we have different ethnic groups We have Afro-descendant groups, indigenous groups, Aboriginal groups, and so actions have to be differentiated. So work has to be done to identify differential costs, different service modalities. Even within a country, you cannot have just one package of programs. And we need to factor that in the short, medium, and long term as we move from our policies. Yesterday, someone said it was fundamental to have political will. Yes, for a start, you need that support, investment, and decisiveness, but the big thing is to move from the policy of an administration into making it truly a government, a state policy that will last for the long term. Thank you.
Muchísimas gracias, Constanza. Quentin.